To introduce our speaker today, Dr. Paul B. Kaplowitz. Dr. Kaplowitz is a professor of pediatrics and the chief of the Division of Endocrinology here at Children's National. He's practiced pediatric endocrinology since 1982, the year after I was born. He has over 50 publications, including authoring 2 books. He's a nationally recognized speaker and expert on the topics of puberty and growth disorders. Dr. Kaplowitz attended the University of Michigan for undergraduate and then went to the University of Chicago for his MD and PhD. He completed his pediatric and pediatric endocrinology training at the University of North Carolina in Chapel Hill. From 1982 to 2003, he was on the faculty at the Medical College of Virginia, and then in 2003, he joined us here at Children's National as the head of the Division of Endocrinology. He served as the chairperson for the AAP section on endocrinology since 2009, and with the World Series going on right now, I must mention that he's an avid baseball fan. So without further ado, it gives me great pleasure to introduce our speaker, my mentor and friend, Dr. Paul Kaplowitz.
Well, I have been here, as Dan said, since 2003. And this is the first time I've actually given grand rounds. And it's nice to be able to talk about a topic that I think people hopefully will see applies not just to my field, but to all of pediatrics and all of medicine, and something that I feel very strongly about. So the things that I hope to cover today are the following. We want to talk about how much does unnecessary or excessive diagnostic testing, which would include both lab testing and imaging, add to the annual costs of U.S. healthcare. We'll try to define what we mean by unnecessary diagnostic testing, and I'll try to provide a number of examples, both from the inpatient and the outpatient setting, of unnecessary diagnostic testing. And since my field is endocrinology, a lot of the examples that I use will be from pediatric endocrinology, but I think you'll see that they're applicable to other specialties as well. As we go through this, you'll see some of the negative consequences of excessive testing, and I'll also try to address some of the factors which may be contributing to the rise of unnecessary tests in recent years and some of the barriers to actually reducing them. And then at the very end, we'll talk about some of the things that we might be able to do here to reduce unnecessary diagnostic testing. But to start off, defining unnecessary testing is difficult, and also trying to define how much it costs. So how big is the problem? Well, I Googled a lot of variations of unnecessary, excessive annual costs, and it was hard to come up with a good estimate. Here was one estimate that just talks about, that was by Obama's former director of the Congressional Budget Office, who estimated that 5% of the national gross domestic product, $700 billion a year, goes to tests and procedures that don't actually improve health outcomes. And everybody agrees that the high cost is a problem and it must be addressed. I think that the best estimate is that it's a lot of money, but nobody could even agree on how many zeros. So here is another estimate. This was specifically addressed towards the practicing defensive medicine. And most agree that the costs of defensive medicine are very high. And this particular report from the Massachusetts Medical Society estimated that defensive medicine, a lot of which is diagnostic testing, costs the American healthcare system in excess of $100 billion a year, which would account for up to 12% of all healthcare expenditures. So whatever number you pick, it's a lot. So the question is, how do we define unnecessary diagnostic testing? And I've tried to put them into different categories. And one category would be tests that are very unlikely to provide useful information that will actually affect patient management because they may not be appropriate for the patient's problem. It may be that they're appropriate, but we have enough clinical information to manage the patient without the test. So they're kind of interesting stuff, but we don't really need them. And then, I think a very common one is that the condition that is being tested for is a very rare cause of the patient's problem. And, to give you an example, if you're working up hypertension, do you really need to to do urinary testing for pheochromocytoma. I can tell you that it's often done. I've still yet to see my first case of pheochromocytoma in 29 years. The problem is that there's no consensus as to how rare a positive result would be for a test not to be worth doing. I think we would all agree that if the pickup is 10%, everyone would say, "Oh, that's pretty high." What about 1 or 2%? Then I think some people are going to say, "Yeah, that's an awful lot of testing for 1 or 2%." But a lot of the testing that's done probably is more like 0.1%. So unfortunately, there's no consensus, but frequency of positive results is important. Another category of unnecessary testing is screening tests done for patients who have no specific signs or symptoms. The idea being we're going to catch disease early. And, I think there's lots of, we'll talk about some specific examples of that. One of the things is that we now have screening tests that review panels have looked at and said, this is not cost effective. And so I think we could include those tests, the ones that have been analyzed carefully, in the category of unnecessary, but they're still being done a great deal. Another category is repeating tests that were recently performed. This is more in the inpatient setting. Repeating tests that the patient's clinical status really hasn't changed. You don't need them, but people feel the need to repeat certain tests. It's particularly true with tests that don't change very much. One hospital found that serologies were being repeated all the time. Serologies, they're either positive or negative, but their change doesn't reflect whether the patient is actually improving. And then there's one category that I think is particularly interesting because this is the one that could actually be attacked by developing compatible electronic medical records. A lot of times we see a patient and we know, either in our office or in the emergency room, and we know that tests were done at another facility, or the parents tell us, but we don't have any way of accessing that. In the best of worlds, the patient would either, bring the tests along, but a lot of times we don't have it. And so we have to decide, do we repeat it, or do we hope that, and this problem would be much easier if we could access the records from other hospitals. One of the problems in defining it is that there really is no standard definition of what constitutes unnecessary or excessive testing. I found a study from 1998 which looked at 44 papers which tried to apply criteria for what was unnecessary. And 33 of them used explicit criteria based on, was the test choice appropriate, the frequency and timing of the test, and the possibility of positive results. But in this study, they found that the estimates of inappropriate use were all over the map. They probably averaged sort of like 30%, which is a figure that I've seen a lot, but they ranged from 4.5 to 95%. And it sort of reminded me of a famous comment by Supreme Court Justice Potter Stewart. When asked to define hardcore pornography, he said, I can't define it, but I know it when I see it. And I think many of us feel that way about unnecessary testing. It's hard to define, but we can, we know it when we see it. So let me give you some examples of tests that are not appropriate for the problem. In my area, one of the biggest is thyroid tests. And I'm not just talking about, a T4 and a TSH, but total and free T4, total and free T3, which are totally worthless, and thyroid antibodies in situations where the chances of finding a clinically significant abnormality are low. And that would include obesity. Believe it or not, it's a widely entrenched belief out there that thyroid, hypothyroidism causes obesity, and it's not true. Fatigue, anxiety, and a lot of patients get tested because there's somebody else in the family who's had a problem. And, so if there's a goiter or symptoms of either hypo or hyper, that's appropriate. But for these other situations, very, very low yield. One of the cases that I saw recently that particularly troubled me was a primary care physician was evaluating a 15-year-old for amenorrhea. And she ordered not just one, but two brain MRIs. The reason I think the first one was technically suboptimal, so it was repeated. And this was after the primary care physician had already ordered all the usual lab tests, including the serum prolactin, which was normal. Now, nobody would order an MRI for amenorrhea unless the serum prolactin was elevated, which doesn't happen very often. But this is an example of an inappropriate use that has no chance of addressing what the patient's problem is. By the way, does anybody here know what the average, on a national basis, what the average cost of a brain MRI is? Anybody else? Yeah. Well, it's over $1,000 for sure. The average charge, the technical fee for a brain MRI with and without contrast around the country is between $2,500 and $3,000. But then you have to add to that our professional fee for interpreting, so you're getting up at least $3,000 for an MRI. Now, CT scans are less, but people tend not to use them because they deliver more radiation. So what about labs? Another example from my own practice is labs for evaluating short stature in healthy children. So this is a common scenario. A pediatrician sees a 10-year-old who is concerned about it. The boy is concerned about his growth. And his parents are short, but they have the growth chart. And he's pretty much been following the 5th percentile for a number of years. He really doesn't have any known health problems. He's active in sports. And so here are the options that the PCP has. He could try to reassure the family that his growth is normal. Or he could say, do a minimal workup, maybe a bone age, and then refer to a specialist. Or he could order the standard battery of labs, which include all of these things. So does anybody want to take a stab at how much that standard battery of labs would run? Anybody? Somebody says 1,000. Anybody for lower or higher? Actually, 1,000 is pretty darn close. About half the time, it seems, that primary care physicians select option 3. And I have never in my year career seen a situation where a healthy child growing at a normal rate has a clinically significant finding. And yet, this is what is done, and here's what one commercial lab in our area charges. Now, we all know that what insurance pays the lab is less than what's charged, but imagine if you didn't have insurance, you're going to get charged this whole amount. And you can see that some of these tests are not particularly expensive. I guess CBC is so automated that it's actually fairly cheap. Comprehensive metabolic panel. But by the time you get thyroid tests, they're surprisingly expensive. I mean, they're so simple. The actual cost of running these tests is probably really little, but they charge quite a bit. And then more specialized tests like IGF-1 and BP3, which are screening tests for growth hormone deficiency. And then a current favorite is the celiac test. And you can see that the TTG-IGA, which is the best celiac test, is only $150, but a lot of people do the whole celiac panel, which I'm sure has gliadin and anti-endometrial. I'm sure that one runs a lot more. And I think that partly I think that specialists have to share some of the blame for this, because when you ask pediatricians why they order these tests, they'll say, well, I looked in the review article and textbook, and you read these things, there's always a list, and they're always lists because they ask you to give a list of what tests may be useful in the evaluation of a particular problem. And these are the lists of tests that may be useful. And we don't say in these articles that you have to order all these tests all the time, but I think that part gets lost. And so I'm starting to think that maybe when we write these articles, we should say something like, don't order anything. If the child hasn't grown in 6 to 12 months, call us. Otherwise, just send us the patient and a copy of the growth chart. And that might help. On the other hand, a lot of people don't read textbooks and articles. They just do it the way they've been doing it for years, and it's very difficult to change this. So what about the use of routine screening tests in kids to, the idea is if you that if you catch disease at its earliest stages, they'll have a better outcome. So I think we all know that many of our colleagues do periodic screening tests at well-child visits, and everybody has their own scheme. CBC, metabolic panels, lipid panels, thyroid tests, and these for patients that are perfectly healthy. I think a lot of people order lead screening too, which may be appropriate in certain geographic areas. And what we find, and I'm sure you've seen this, is that such testing is far more likely to uncover a trivial lab abnormality than anything that we actually need intervention, and that the most likely outcome is that you're going to have to repeat some of these tests that are slightly abnormal. But let me give you a specific example of urine testing. So the question really is, are urine dipsticks and urine analyses positive often enough to justify screening asymptomatic children. And fortunately, the nephrologists have been on top of this, and they have reviewed the available studies. And what they concluded was that the yield in diagnosis of unsuspected chronic kidney disease, nothing on the history or physical exam, is very low. But the real problem is, a urine dipstick or urinalysis is not expensive, but it is expensive when you get a lot of false positives. In other words, you identify people on this test, but they're almost invariably false positives. So there's a certain expense to following up on those. And so basically, they recommended against such testing. Now, another example is, and this is more from the adult world, but I was trying to find articles which address this. This was a headline from 2006, millions squandered in unnecessary tests ordered in routine doctor visits. And the idea is that, people feel, a healthy adult goes to their doctor, and the task force has already reviewed this and said urinalyses, electrocardiograms, and x-rays are not useful as screening tests in healthy adults. And the Hopkins study looked at these and found that they looked at a whole bunch of well adult exams, and at least 43% had one of these three things ordered. And not only were the tests unwarranted, but there was the usual false positive results, which led to further tests and increased expenses. And so their final conclusion was that doctors and patients feel that routine exams should include a number of tests to screen for unknown disease, but the evidence really shows that they're less than beneficial, and their conclusion was that more is not always better. Now, I'm just going to briefly mention this simply because it's been in the news so much. Cancer screening in adults is even more complicated, and it's pretty expensive. And as all of you have heard, there have been these recent rather acrimonious debates over the U.S. Preventive Health Service Task Force, which has basically said that there's a low benefit relative to the cost of annual mammography for breast cancer in women between 40 and 50, and also more recently PSA testing to screen for prostate cancer. And as you've heard from the response, this is a very emotional issue. The urologists are just incredibly upset that people are going to be dying from prostate cancer because of this recommendation. But the point is that even when there's ample data on many years of study to show that a screening test is not cost effective and therefore unnecessary, tremendous opposition to changing what everybody says is the standard of care. And one of the things that I'll comment on is the tendency in the hospital for repeat testing. There are certain labs, particularly CBCs and metabolic profiles, which tend to be ordered daily or in some cases more often, even when the clinical situation doesn't really demand such frequent testing. But I think the example that stands out for me, because my taking care of patients who come in diabetic ketoacidosis, is blood gases. And blood gases tend to be done, at least every 2 hours and often every hour in the emergency room and in the intensive care unit in diabetics, even when the patient is clearly showing improvement. So the question is, how much is this costing us? Well, it's interesting. You look up the charges. I think most people don't know how much. But there's something called the iStat EG7, which includes a venous blood gas, hematocrit, sodium, potassium, and ionized calcium. That we charge $770 for. It turns out that there's a cheaper test that we could do. We could just do the blood gas and charge only half that, which is still a lot. But a lot of people don't realize that, and so EG7s are ordered very routinely. And even when patients are in DKA and clearly sick, there are other ways to document clinical improvement. The physical exam usually gets better. The vital signs will show the heart rate is going down as they're less dehydrated, they're breathing less fast. And the other thing is that you can definitely track the improvement in acidosis with a serum CO2. It starts out at 5 and it keeps going up. I think one of the objections that people have is that maybe it takes an hour or so to get a serum CO2 back, whereas a blood gas comes back like that. So people need instant feedback, but the patients will do fine either way. And so one of the problems is, and I'll come back to this later, is that our lack of awareness of how much these tests are costing drives up our average cost of admission. Let me give you an example that was fairly recent of a 15-year-old. This is a child who had recently been diagnosed with type 2 diabetes, and he came to the emergency room for nausea for 5 days, not vomiting, no other complaints. And this is a sort of a copy of the blood gases that were done. In a 3-hour period, actually less than 3 hours, this patient had they actually had the whole EG7 because each of them included the hematocrit and ionized calcium. And the first one was, as you can see, was clearly normal, but obviously the second and third were normal too. And I asked Jim Chamberlain to check out what had happened, and he did check. And it turns out that these were ordered by a nurse, not by an attending, not by a resident. But the nurse decided that this, it's a diabetic. They came to the emergency room. They needed to be on the DKA protocol, and the DKA protocol says that you need to get blood gases every hour. So an example of unnecessary tests that could have been avoided with a little common sense. We find, at least in the outpatient area, that how test reporting is done contributes to testing overuse. And basically what you have is, what defines the normal range is 95% of healthy individuals. So you're basically 95% confidence limit. But anything, even slightly outside that, gets labeled as H or L. And I have a feeling that seeing an H or an L just triggers some response in doctors that, oh my God, we got to do something about this. And the truth is that what we really probably need is a third category. We probably need a category of critical, or like maybe we ought to define it as, above the 99th or below the first percentile as, this may be something that you really need to worry about. So I think that flagging very abnormal tests differently than borderline abnormal tests might reduce anxiety and reduce some of the repeat testing that we see. And I think one of our problems is that we don't always do well distinguishing benign normal variations for results that actually related to the problem which prompted the ordering of the test. People do thyroid tests for a large variety of reasons that I mentioned, but we are constantly getting referrals for patients who have a normal free T4 and a TSH which is just barely outside the normal range. And do these people really have thyroid problems? No, they're normal variations, but it's very difficult to convince primary care physicians of that. And we're not, obviously, you can see how this would apply in other departments. I know that nephrologists see a lot of referrals for renal tubular acidosis because the patient has a CO2 which is slightly below the reference range, 17 or 18 with the reference range of 19 to 28. And I would imagine that very few of these cases actually prove to have RTA. And I talked to the hematologists and found out that their most common unnecessary referral was a patient with a normal CBC, except the platelet count is slightly elevated. What do you do about it? Nothing, but patients are seen, generates another consult. Another thing that one of the things I find that pediatricians do is they don't always refer the patient right away, but they repeat the test to confirm the abnormal result. And in my experience is that if you have a borderline abnormal result and you repeat it the next week, it tends to stay borderline abnormal. So then they go ahead and refer, and that generates extra costs. And by the time we see the patient, they've had 2 or 3 blood tests, and the parents are quite anxious, and it takes a while to convince them that this is not something that needed to be addressed. Let me give you an example of how unnecessary imaging gets us into trouble. Here is a child who has a goiter. So the pediatrician does an exam, and they say, yep, thyroid looks enlarged. And they don't palpate any nodules. They do a free T4 and TSH, which is appropriate. And then they decide, well, just to be sure I'm not missing anything, I'm going to do a neck ultrasound. So what happens? The neck ultrasound confirms that the gland is enlarged, so we know that the physical exam was accurate. But it also shows heterogeneity consistent with thyroiditis and 3 micronodules, about ½ centimeter in diameter. So what do you do in this case? You repeat it in 6 months. You tell the parents that the child needs to be seen by a specialist to rule out thyroid cancer, or do you basically say, no big deal? Well, it turns out that option 2 is often the one that's selected. And so in order to evaluate whether that's appropriate, we need to give you some additional information. Thyroid cancer is rare. I mean, we do see a couple of cases a year, but it's not a common problem. And it presents usually as a large solitary nodule. And the general consensus among people who care for large numbers of these patients, particularly adult doctors, is that nodules that are less than a centimeter are rarely malignant, plus they're really too small to biopsy. So the general consensus in adults is unless there's risk factors like neck radiation or family history of thyroid cancer, we don't worry about nodules less than a centimeter. And the other thing is that if you took normal individuals and and did a bunch of ultrasounds, the incidence of these micronodules is actually pretty high. I could not find a reliable incidence, but my sense is that at least 20% of normal people have tiny nodules. But once you've identified the problem, a lot of people feel obligated to subject a child to yearly ultrasounds just to make sure that the nodule is not growing. The cost, it's not as expensive as a brain MRI, but it's not cheap. And you imagine that parents, being asked to do this every year are going to be worried that something is going to show up, but the child doesn't get any health benefit. And you obviously can see how the same thing would apply to the incidental finding on a brain MRI. I mean, in our field, we get a lot of referrals for 3-millimeter pituitary microadenomas, but there are a lot. If you do enough brain MRIs, you find a lot of findings that are not the reason why the patient, they don't explain the headache, but people feel the need to follow them up. So I'm going to shift gears and talk about why has the amount of unnecessary testing increased so much in recent years. And I think that there are several factors that contribute. I think many people feel that the whole issue is that doctors fear of being sued if something serious is missed. And the corollary to this would be if we could only reform malpractice, this would dramatically reduce the cost of health care in the U.S. And I think it's valid up to a point. I think it could explain the tendency to order brain imaging for acute onset of headache or minor head trauma in the emergency room, even if the history and physical is not particularly suggestive of intracranial pathology. And I think there are guidelines as to when MRIs need to be ordered for head trauma, which would suggest that most of the time they don't need to be. And I think it also might account for some of the repetitive testing ordered in a critical care setting if the staff believe that more frequent monitoring will prevent more adverse outcomes. But I think it's more than just defensive medicine. Does practicing defensive medicine explain the overuse of outpatient labs for kids who have a variety of non-critical symptoms, short stature, behavioral issues such as anxiety, attention deficit disorder, or the family history? When you think about it, these are situations where there's no rush. Pediatricians have time to take a history, do an exam, and they can tell the parents that if the parents come in requesting lab tests, they can say, in my experience, these tests are really not going to help us. But a lot of times we bow to parental pressure because parents want you to do something. But I think it's even broader than that. I think that there's a problem with the way physicians think and process information. I think that for many doctors, being complete and thorough in evaluating persistent non-critical symptoms is more important to them than being cost-effective. They don't want to leave any stone unturned. I think that we all appreciate that at times testing becomes a substitute for clinical judgment, for that time-honored tradition of talking to the patient and laying on of hands. And I think there's also the parental expectation aspect. If you come in with a complaint, you should get a test. And I think that we would all do better if we would feel more comfortable telling families that many complaints resolve on their own, and that most complaints that people come in with do not have a lab test-related cause. But I think that the problem may even go back to the way we train medical students and residents. This is not my area of expertise, but I don't know that we do enough in the training of our next generation of doctors to impress upon them how the history and physical has to take primacy over diagnostic testing. And one example of how testing sort of can run amok is lab tests for fatigue. We had a grand rounds recently on fatigue that was thought to be due to this was Lyme disease. The patient had an extensive workup, but fatigue is one of these things that generates a large battery of tests. And, we already, when a patient gets referred to me for fatigue, I usually, they don't tell you, what we do in our office is if somebody has a lab test related reason for referring a patient, we ask to review the labs. And so 5 pages of lab tests come through, and you flip through them, and there's the CBC and the metabolic profile, but then you have pages upon pages of serology results. So it's a pretty extensive battery. And this particular study looked at 22 adults who had fatigue for greater than a year. So this is a pretty, significant degree of fatigue. And all of them had a standard battery of tests. And what they found was that a few of the tests were abnormal, but the abnormal tests all eventually returned to normal, and none of them really, related to the fatigue. But what they did find is that when they gave patients like this a psychiatric symptom checklist, they often identified a tendency towards either depression or paranoid ideation. So their conclusion was that, at least in their patient sample, lab studies were not helpful in guiding evaluation of fatigue. But I think what we run into is a problem when we try to relate vague symptoms to some abnormal lab finding. I think the way we should proceed is we should listen to the patient complaint, generate a list of possible diagnoses that is at least hits the top few, but is not doesn't go down to the very bottom, and then do very targeted testing, or perhaps no testing at all. But what ends up happening is the patient has a complaint, and we start throwing darts at it, hoping that one of them, if we do enough tests, one of them will stick. So we do all these tests. The interesting thing is that the latest test that seems to be added to the armamentarium is the vitamin D test. And, we all know that, vitamin D deficiency, if you define it a certain way, 2/3 of people in this country have suboptimal vitamin D levels. But the number of patients who actually have severe vitamin D deficiency that causes symptoms is really, really small. But I've had patients referred to me because they had leg pain or difficulty walking, and the vitamin D was 23. So, yeah, you got to see the endocrinologist, because this is why your child is having trouble. And one outcome of excessive diagnostic testing is the simple mathematics of it. If you do one test, 5% of patients will have an abnormal value. If you do 2 tests, 10%. Now, it doesn't go up exponentially, but by the time you do 20 tests on a single patient, there's a 64% chance that one of those test results will be abnormal. So what are some of the barriers to reducing unnecessary diagnostic testing? Well, the main obstacle, as I see it, is there really isn't any incentive. Our healthcare system tends to pay without question for almost any diagnostic test ordered by a doctor if the patient has insurance. The same is not true of costly treatments, which are scrutinized and sometimes denied, sometimes appropriately and sometimes inappropriately. There's also no easy way to deliver feedback to physicians who have ordered too many tests unless they happen to work for an HMO. And I think HMOs tend to monitor how much tests their doctors order and compare it with other doctors in the specialty. So those people do get feedback, but most physicians don't. And, the other thing is, other than the feeling that you're doing the right thing, there really aren't any incentives or rewards for being a cost-conscious physician. We recognize people who do the most surgeries or see the most patients, but nobody really pays any attention to who orders the fewest tests. To put this closer to home, physicians who work in hospital settings are rarely discouraged from ordering too many lab tests and imaging studies. And part of it is that the extra tests are usually covered at least partly by insurance, and they generate revenue for the hospital. Now, if pediatric admissions were reimbursed based on DRGs, as happens in Medicaid, rather than the actual charges that we accumulate, that could change. But as of now, we're still paid on a fee-for-service basis. And the other thing is that insurance doesn't deny coverage for outpatient testing very often, except for the most expensive tests. So we have had situations where genetic testing, which can run into the thousands of dollars, may not be covered all the time. But part of the problem is that the reason why insurance haven't attacked this is that it's very hard to define what's unnecessary. Now, you may ask, well, we have this new healthcare Reform Act. Will this do much in this area? And there really isn't a whole lot in the ACA Act that is going to do this, except that they are encouraging the setting up of ACOs, or accountable care organizations. The purpose of those is to develop a team approach to medical care among a group of doctors, which in theory should lead to less expensive care and less testing. But ACOs are only projected to be a small segment of the healthcare market. Another problem that I've noticed is that there's very little effective advocacy for reducing diagnostic testing at either the regional or national level. I'd like a show of hands. Has anybody been to a national meeting and heard a talk on excessive diagnostic testing and how to combat it? Ah, good. One. You have?
No, we have.
Okay, three. Okay, but not many. And I think that as I've talked to some of my colleagues, I think a lot of physicians are reluctant to speak out because there's this general feeling like, well, doctors don't want to be told how to practice medicine, which I think was fine in the old days when we weren't spending ourselves into huge deficit with healthcare spending. And the other feeling is that people don't want to write guidelines because they say, well, if we write a guideline, then the insurance companies will use it as an excuse to stop covering a particular test. Well, I think that's kind of part of the point. If you don't write a guideline and say this test is unnecessary, then people will continue to use the test unnecessarily and it will continue to get covered. Does it help to inform doctors of the costs of their unnecessary testing? And I tried to research this, and there are a few studies that looked at, can we intervene and figure out a way to give people feedback? And this was one study that was done both at Brown and University of Miami, and they were concerned about the cost, hospitalized patients getting daily CBCs and chemistry panels. And what they did was they targeted the surgical service where this tended to be a bigger problem, and they gave weekly announcements to the attending and house staff that don't order these tests, on a routine basis. And what they found was that a reduction in the daily cost of these tests from $147 to $108. So they did, in the short term, reduce costs by 27%. But other studies have found that the effects of such interventions tend to be very short-lived. You can do it for a while, but if you stop, things go back to where they were before. So it's expensive to figure out ways to keep this on their radar screen. One approach is kind of that it has occasionally been tried is redesigning test request forms. There was a study from France from about 20 years ago where they found that people were ordering the wrong tumor markers. They were ordering tumor markers that didn't address the particular tumor that they were worried about. So they developed a sort of a matrix whereby this column was the list of organ systems, and this column was the list of markers, and you would be directed to order the test that fit for your patient. So if you're worried about ovarian cancer, you would order this test, but not all of these. And what they found was that there was a 25% decrease in tumor marker testing, so a slight improvement. So to wrap up, why should this matter to us? Well, I have been told that our cost for admission is one of the highest in the region, and that some insurers are sending their patients to other facilities. So we need to address this. Another thing is that a high proportion of our lab tests and imaging order is done by residents, and that's an important driver of inpatient costs. And I think that in general that we have to recognize that a lot of times when we test, we are going on a fishing expedition, and if we order enough tests, and this is particularly true with patients who come in with problems that it's not clear right away what to do about it, that we always get abnormal results. Valuable time is lost in repeating them. Unnecessary consults. I would say I can't count the number of times when we were asked to consult because of a slightly abnormal thyroid test where the thyroid test probably should never have been ordered in the first place. So we get unnecessary consults, and then try to explain this all to the family, and the family gets confused and overwhelmed. And I think the other thing, we are an educational institution. We are training the next generation of pediatricians, and sometimes it seems that they're learning to place a greater value on testing over the careful history and physical and the targeted ordering of tests to investigate not just everything but the most likely problems. So what can we be doing about this? Well, I think that we could definitely do a better job in incorporating awareness of cost of diagnostic tests into our teaching rounds, our professorial rounds, and formal lectures that we give to residents. I think that we should emphasize to our trainees that tests should be ordered to rule out plausible diagnoses, and it's rarely necessary to rule out every conceivable diagnosis listed. And I think in terms of repeat testing, we know that we need repeat testing to monitor response to therapy, but we can be, I think we can take care of our patients with less frequent and more targeted testing. And a couple more suggestions. I think this is very doable, but we could configure our electronic records so that when certain high volume or certain high cost tests are ordered, the charge pops up on the screen. And we could even have Cerner remind those ordering tests of a less costly but similar test. One example is ordering total calciums versus ionized calciums. When a patient first comes in with hypocalcemia, I think it's reasonable to do one test where you compare ionized and total, and if they're both low, you can track the improvement in the total calcium, and the difference in charge is 59 for a total versus 208 for an ionized. And to go back to my previous example, with blood gases, people can be said, just order the VBG. You don't have to order, which is half as much as the whole ISTAT panel. And I think that those of us who attend can monitor test ordering on the patients on your team. And I think you should be challenging your trainees to justify ordering tests that do not contribute to clinical decision making. And in addition, when you get a consult, I think we've all had the experience of ordering a consult, and the consultant says, well, I'm not really sure, but it could be one of these things. And they give you a long list of tests, and you say, how is this going to help us take care of this patient today and tomorrow? I think it's very reasonable to question those test ordering. And to speak to our physicians in the community who may be listening in, I would encourage physicians who refer us patients to take advantage of the expertise of our specialists. Don't try to guess what tests we would order for a certain problem. Many consults that I do require no tests at all. Unless there is a simple blood test, which, if normal, would make the referral unnecessary, like you think it might be diabetes, so you want to check a blood sugar, it's usually best to leave the test ordering to the doctor who will see the patient. If you feel that the situation is urgent enough that it can't wait until the next opening of the schedule, then I think it's perfectly appropriate to contact an attending by either phone, fax, or email to request guidance or an expedited appointment. So I think the ultimate challenge is really to change the culture of medicine. And it was put very eloquently by Steven Weinberger in a column for the American College of Physicians. What we need is a change in the culture that embraces the appropriate integration of physician-acquired information with diagnostic testing in a way that is evidence-based and takes both absolute and relative costs into consideration. This cultural shift must start with medical student and resident education and must extend to the level of individual practicing clinicians. Why? Because the health of our healthcare system depends on it. Thank you.
Thank you very much for this wonderful, very timely lecture. If we have any questions, please come to the microphone, and we actually have a question on WebEx too to address.
The generalist pediatricians. And just a couple of things I also wanted to commend you on is the emphasis on clinical reasoning and taking into account the history and physical, and the physical as being part of the diagnostic testing. I think that's something that we fail to appreciate. And then just one other thing to let people know that Ellie Hamburger and Devesh and a number of others with the residency program are applying for an American Board of Pediatrics Innovation and Pediatric Education Award, which will focus on the correct ordering of consults from both the inpatient and outpatient setting, and I think hopefully address a lot of the issues that you bring up for resident education. Thank you.
Thank you.
Hi, as an ancient primary care practitioner, in the old days, and you've mentioned it here too, there's nothing better than a little bit of communication from the primary source who's concerned or worried, being able to talk to the specialist and say, what should I do next? And if we don't have that, then you get a lot of this dumping and all kinds of stuff done. So a little talk ahead of time is worth a lot of time and money.
Yeah, I think you're right. I just got a call the other day from a physician saying, I have this patient with a whole bunch of complaints, and none of them, of course, hung together. And the mother wants to order tests. What should I order? And I said, I don't think that you really should order anything. But I think it was important that the physician felt comfortable calling and requesting advice before they went ahead and did the $1,000 workup. Brian.
Paul, thanks for the great talk, very timely. So a couple of comments and then a question. So first comment is I think what you're discussing this morning around unnecessary diagnostic testing, it probably represents a microcosm of waste in the organization. And the same discussion can probably be held for unnecessary blood product testing or staying an extra day just to watch the patient or what have you. So I applaud you for bringing this topic up here. The one comment I wanted to make is we've seen quite a transition in the way our payers reimburse us over the last decade. And although 10 years ago it was true that most of our reimbursement was fee-for-service, we're now seeing a shift in that, and I think that's going to continue to shift over time. So today, my understanding is that only about a third of our patients are reimbursed by fee-for-service. A third of them are paid per diem, so you get paid per day, and a third are being paid for the case itself, case rate. So, and it's a very important financial issue because the fee-for-service patient, we're going to make more as an organization the more testing we do. And that must be addressed before we're able to get on top of this issue. As we get more toward bundling or capitated care, if we do in fact move in that direction, there'll be more and more incentive to not do that. I think our challenge as attendings and leaders in the organization is to translate that organizational imperative down to the grassroots level there. So the question I had for you has to do with frequency of lab test ordering there. And I think we have a culture here that is very permissive. We've made it very easy to order very frequent lab tests. You can go into our electronic health record and you can order blood gases Q1 hour or CBCs daily or chest x-rays Q6 hours or what have you there. And there are no limits to that at all. So the question is, there's a proposal on the table as we speak to eliminate the ability to order frequent tests, but just go in and only order one-time test there. And I'd like to get your thoughts about whether that's a good thing to do or a bad thing to do.
Well, obviously, I think it's a step in the right direction. I think that, it's too easy to do what you say, to order, a Q2 hour or Q day. And I think if people have to think, is my patient getting better? And do I know my patient is getting better? Maybe we don't need that test. I mean, there's certain things that you do need to test every day. If, to give the hypocalcemia example, if the patient's discharge is going to depend on when his calcium normalizes, yes, you need a calcium every day. But there are many tests that we do on a routine basis that aren't going to affect clinical management. I think forcing people to decide each time they need to order a test will certainly reduce the amount of tests that we do. Naomi?
So as the director of the lab, I'd like to say that we would like to be put out of business. We think that we do entirely too much testing, and actually the emphasis to decrease this ability to order PRN Q15 minutes, which we also see from the PICU and the CICU, is totally inappropriate. What we would like to see, if it's at all possible, is pop-ups and the information fed to you. You have done a CBC for the last 15 times and the hemoglobin hasn't changed. Are you sure you really want this CBC? Unfortunately, at this point, I don't think we have the infrastructure to make that happen, but hopefully we will in the future. Apropos of how much a test costs, I just want to let everybody know that all you need to do is to go on to the intranet, to the lab, to Lab Information System, and you will see the price of every single test that we have built. And if it isn't built, that means it's a send out, and you can be pretty much assured that it's in the 500 to 1,000. And we also have 4 or 5 tests institutionally which are running at $15,000 per single test. Those obviously need pre-authorization. So another thing I'd like to see on your algorithm of what else can we do is to put in some systematized ways to ensure that insurers will pay for these highly expensive tests, because parents are getting balanced bills. Parents are getting bills for thousands of dollars, which they can't pay.
Yeah, Naomi's absolutely right. I did find the blood gas information was definitely on the internet, but you know, how many people when they order a test are going to go to the internet and say, you know, I think that having it pop up. Brian, do you think that's a possible enhancement to Cerner that is feasible?
Yeah, no, I think that's very feasible. I think we're challenged with doing this for 500 tests, but I think if we could target some bad actors out there and do something that would be fine. But I do have to push back a little bit, though, because the technology is not going to help everything. A lot of people ignore pop-ups and
Yeah, you're right.
them and all those
Yeah,
things.
they help at the beginning, but then they get used to it.
I really think that this starts with the leadership of the Ramsey team. So I'll reflect back on rounds in the ICU last time I was on service, where there was a dialogue between the resident and the nurse. The nurse said to the resident, "How often do you want blood gas?" And he said, "I don't know, 2-4." And so they ordered those whatever $300, $700 eye stats every 4 hours, despite the fact that the last day's worth of blood gas and the pulse oximeter and the Untitled CO2 were all normal.
Yeah.
And so what's the role of the attending in that scenario? And I'm standing back there listening to this, and you know, so for me, I said, all right, hey guys, why are we getting blood gases every 4 hours? They've all been normal, and that one action in and of itself changed the frequency.
I agree
There is
completely.
a role here of the team leadership in ensuring that.
Yeah.
Well, actually, that leads into exactly what I was going to ask. Ask Paul is you spoke, and that was a wonderful talk. And most of your concentration on the way we can fix this is with education, and I think that's an important part. Just like if you put the cost of each test into Cerner, when you click on it, it gives you the cost. Just like when you go to McDonald's, it gives you the number of calories, and you may choose to eat healthier if you have the information about the cost of the test or the calorie of the food. My question, which was a good segue from what Brian was talking about, is your thoughts on the role of clinical practice guidelines or standardized clinical management plans like your DKA plan, and how can we keep those current? Do we utilize them globally so that people aren't doing unnecessary testing, unnecessary lab ordering, imaging, and things like that?
Yeah, I agree that clinical management guidelines are helpful in certain situations. What I have found is that sometimes clinical management guidelines tend to be very more conservative than they would like. They don't want to, always say, you really don't have to do this for the very reason that I mentioned earlier, is that somebody's going to say, oh, we don't want to tell doctors how to practice. But I think that clinical management guidelines could certainly be a way to provide cover for people who want to do fewer testings. If pediatric endocrinologists said in a short child you don't need to do tests, but unless the child has clearly decelerated, well, I think that might help. But I think that it takes more than just clinical management guidelines, because a lot of people don't pay attention. But I think each service needs to develop their own teaching efforts, and I applaud Brian for making that excellent point about what happens on rounds.
Thank you. I apologize. We have time for one more question, but I just first want to do the question from WebEx that's been pending from Dr. Fields. It's more of a comment and a question. From the point of view of CNMC, you have pointed to residents as part of the problem. How about those of us who have been practicing for 20-plus years when the cost was not a problem and we're used to shotgunning? Perhaps the problem starts with us?
I didn't hear the last part.
Perhaps the problem starts with us?
Well, I think I tried to make that point, and I'm very glad that we have people out in the community who are hearing this message and hopefully will, start to think a little differently about how they approach diagnostic testing in their offices.
Thank you very much. We have time for one last question, please.
Thank you. I'd like to give a historical note about this situation. Some years ago, a pediatric mentor of mine told me that in the days before antimicrobials were available to treat patients with pneumonia, the following of patients clinically was enhanced by obtaining CBCs every 6 hours.
Okay.